Okay, I think I've figured this out. So if anyone has any problems, just make sure to get in touch with me. And again, please email me with any questions you have about this lab. Be precise when you're doing this lab report. A lot of little things that I ask for that uh, a few of them, some of the other classes didn't really think was that important, but are. And we'll talk about those at the end of the slideshow. I'll go through this as quickly as possible because I know I talked about the basics with you guys, but anyway, here we go. So as an exercise physiologist, we're required to have a proficient ability to interpret the information given to us from a ECG machine. So we'll use ECGs on patients or subjects to check the current status of their heart, if they're at high risk for cardiovascular disease, have had symptoms of a heart attack, previously had a heart attack, or want to participate in certain maximal exercise tests. Um, Through this, we're able to evaluate pacemaker function, response to medications, certain baseline recordings before, during, and after a medical procedure. And also, this isn't the I guess main purpose, but it is a great way to measure heart rate, and you'll see that there's various ways to estimate that that we'll talk about today. And again, I apologize for the laryngitis. All right, so for a quick overview of heart electrophysiology, if our heart's functioning normally, the heart depolarizes from the SA node with an inherent rhythm of about 60 to 100 BPM, depending on several factors. As the electrical activity flows from the SA node to the AV node, pauses for ventricular filling, and then permeates through the bundle of His into the left and right bundle branches, and then into the Purkinje fibers. The depolarization and repolarization of different areas of the heart can be mapped using our ECG tracings. For the P wave, we see that signifying atrial depolarization. Okay, the PR interval is the length of time right here. The PR interval is the length of time that it takes for the AV node to activate. So a delay exists here, so blood can fill into the ventricles before the ventricles actually contract. And then we have the QRS complex, which signifies ventricular depolarization, as well as the hidden atrial repolarization. This is hidden because atrial repolarization is a much less powerful signal than ventricular depolarization. Okay, and then at the point where the S segment of the QRS changes direction. Okay, so right here, this is known as the J junction. A deviation at this point is an important indicator of heart function and injury, and we'll talk a little bit about that later. And then we have the T wave, which signals ventricular repolarization. All right. So on the tracing, the signal will look more like this. When we print out an ECG recording, the x-axis is in time, so specifically in milliseconds, and the y-axis is in the amount of electrical activity in millivolts. Every small box is 1 millimeter high and 1 millimeter wide, and it represents 0.04 seconds. All right, so each large dark shaded box has 5 1 millimeter boxes in it, thus representing 0.2 seconds. Heart pathophysiology can be determined if the electroactivities of specific waves do not fit into specific time periods. For instance, if the PR interval, again right here, and I hope you can see my mouse, you may not be able to, but we'll work with that. If the PR interval is more than 0.2 seconds or one large box, this indicates an AV node block. For some reason, it's taking a longer time to propagate the signal from the AV node to the ventricles. Also, if the QRS complex is wider than 0.12 seconds, it may indicate certain pathologies of the ventricles. And then the height of the waves imply the magnitude of electrical activity. Clearly, the QRS complex is much taller than the P wave because ventricular contraction and depolarization is much stronger than atrial depolarization. Right? The height of the QRX also may indicate pathology such as ventricular hypertrophy, which could be either from heart disease or even from a highly trained heart. Right? So imagine you've opened up a newspaper to the classified ads, and this is the car for sale. Someone's asking X amount of dollars for it. Would you feel comfortable? Oh, I'm sorry, that was disgusting. Purchasing this car based upon the picture. And this would be a little in-class activity, but we won't worry about that. No, you would want to see what? Maybe the side of the car, the back of the car, the tail lights, different perspectives of the car. So similarly with an ECG, you may not be able to see a certain wave in a given lead, but with 6 limb lead positions, it should show up better in some leads. So in summary, every lead out of the 12 leads that we're seeing gives a different perspective of the heart. All right. So monitoring this cardiac electrical activity from 6 angles gives us a much greater perspective. And this is an example of what would be printed out from the ECG, and it's what we must interpret to determine the functionality of the heart. The ones that you have a bit more information, and I think we know the basics of this already. Here we see all 12 leads and then an extra rhythm strip. So leads 1, 2, and 3, AVR, AVL, and AVF. All 6 of these are from the limb electrodes, and then the 6 precordial leads, V1 through V6. And then the rhythm strip, V2 at the bottom. All right. Lead 2 is chosen because of the direction of this lead. Lead most closely mimics the direction of electrical flow in the heart. We talked about this. So to gather this information, we must place electrodes on the surface of the body, on parts of the surface of the body that will pick up electrical activity of the heart. This is something that we don't really need to go into very much because this is what we did in class. But again, we have our 6 precordial leads, which give us a cross-sectional view of the heart, and then the 4 limb leads, which give us a frontal view, with the right leg limb being a ground. All right. So Einthoven's triangle does not include the right leg lead. Let's see. What didn't we talk about in class? So each limb electrode is bipolar, meaning it can hold either a positive or negative charge. This is important because a lead is created by the combination of 2 electrodes, all right, or 2 limb electrodes, with one having a negative charge and one having a positive charge. If electrical activity in the heart is flowing towards a positive electrode in the specific lead, we will see an upward deflection on the printout, like the upward deflection we see in the QRS wave for leads 1, 2, AVL, AVF, and so on. Let's see. The electrodes can also change their charges in order to create different leads to look at different directions. When electrical activity flows from the SA node of the heart through the atria and through the ventricles via cellular depolarization, the activity is picked up on ECG paper, and that's what we're looking at. All right. So looking first just at the 4 limb electrodes, or really the 3 limb electrodes, we can create what's known as Einthoven's triangle. So Einthoven's triangle was named for William Einthoven. He won the Nobel Prize in Medicine for inventing the earliest form of the ECG in 1924. And the triangle is a depiction of electrical vectors of just the 4 limb electrodes, which ultimately create 6 leads. 1, 2, 3, AVF, AVL, and AVR. The AVF, AVL, and AVR signify the augmented leads, and we'll talk about those in a few minutes. So the triangle represents vectors or directional signals, and we can take each lead of the triangle and reposition it onto the heart so that the leads actually intersect. So again, by moving lead 1 directly down, okay, so it stays parallel with where it is right now, lead 2 over to the center, and lead 3 to the center. So they all intersect at the center of the heart. When electrical activity in the heart is directed towards a positive electrode, a positive deflection is created on the ECG strip. So in counter to that, if electrical activity of the heart is going towards a negative electrode, on that specific lead, you'll see a downward deflection. So for instance, on AVR in V2, most of the directionality of the electrical charge is going away from the positive electrode, so we have a downward deflection instead of an upward deflection. So in addition to leads 1, 2, and 3, we also have 3 more perspectives that are created based upon 2 leads with a negative charge and 1 lead with a positive charge. So these are called the augmented leads because we are averaging the signal between the negative leads and sending the signal towards the positive leads. So for instance, for AVR, we take both of these electrodes, so left leg and left arm, and we average the negative charge so we get a vector in the middle, and this is giving us a perspective from right here, right in the middle of those two electrodes, all the way up to the last positive electrode. And again, the pictures on this slide have the electrodes on the limbs. We've moved them to the torso because the angles are the same, and this is what's commonly done for exercise. All right, because you can't exercise with electrodes on your arms and arms and feet. Okay, same thing with AVL and AVF. And again, we do see lead 2 at the bottom because it's used as the normal rhythm strip because of its close approximation to the mean electrical vectors. All right, so each lead sees a different perspective of the heart. It would be very good of you to actually, you'll get points for it. On the printout, you need to make sure to label each lead with the heart surface. I would recommend circling a group of them that are in the same area and just labeling it like inferior or intraventricular, just so you can pick up a ECG printout and have an idea from these groupings where they're looking at. Because a lot of them are grouped together, like the V1 and V2, you can see are just right above each other. Circle them, put one big circle around them, and then you'll know to look there if you want to see what's going on in the septum, right? And this is just another area to kind of show you what each of these words mean. So septal means middle, anterior, front, etc., etc. Right? Baseline prep, we went over this, and what we didn't go over in class. So primarily, we're looking for normal sinus rhythm for our patients in lead 2. What we're looking for first always is a rate. Do we see a normal rate at rest between 60 and 100? Again, it could be, next we'll talk about sinus bradycardia or tachycardia. These aren't things that are issues to really worry about, but the ECG printout will tell you that they exist. So if my rate was 50, it's not going to say it's a normal sinus rhythm. It'll say sinus bradycardia. Is that bad? Well, it depends on your population. Is it a highly trained athlete or just a recreationally trained athlete? Or is it someone that is super sedentary and their heart's just not working very well? All right. Rhythm, regular. So are we seeing the same rate between each of the R waves, the QRS complexes? Is there a P wave present? Is there a P wave married to every QRS wave? So we need a P wave for every QRS, and here that's obviously the case. Is the PR interval normal? Meaning, is it less than 0.2 seconds, right? And is the QRS width normal? Is it less than 0.12 seconds? These are both things that you need to mark on your printout because they will be worth points. All you need to do is say the PR interval and the QRS width needs to be within what ranges, and you'll get points for that, all right? Just label that somewhere on your sheets, very important. So a sinus arrhythmia. This is, there's usually one person in every class that ends up having one of these. People see arrhythmia and they freak out because anything other than normal sinus rhythm, just, who wants that? Arrhythmias are usually caused by changes in respiration. So it's normal rhythms most of the time, and then all of a sudden someone breathes deeply or whatnot, and the rate changes. So you can see in the middle here, the R's are much farther apart than they are in most of the other ones. All right. So rhythm varies with respiration. It's nothing to worry about. So P waves still must be present. The 1-to-1 P to QRS ratio. Normal PR, normal QRS. And if I haven't mentioned it, sinus means that the pacemaker of the heart is the SA node, right? This is very important because if the SA node isn't working, we may have ectopic pacemakers, which change the rate of the heartbeat, and it's just not good for the heart. Bradycardia, everything's the same except for BPM is less than 60. Tachycardia, above 100, everything's the same. So sinus pauses and rest, this isn't important for this lab, so we're not going to worry about this. If you want to look through this and you're super interested, I am, do that. sinus block, it's just a dropped beat. If you added in another PQRS T, it'd look good. All right, you can. If any one of you ends up with that, then I would like you to look into it. But if not, then don't worry about it. Naming the rhythm. So firstly, is it regular? Yes, it is. All the R to R intervals are basically the same. I'll tell you that the rate you can't really tell here, but it's probably around 60 to 65 beats per minute. There's a P wave for every QRS. The interval's small here, and there's a T wave afterwards. It's normal sinus rhythm. All right, it doesn't look 100% normal, but it is. You'll see normal sinus rhythms that look like, I don't know, maybe they're not, but you have to really go through that checklist and see, all right, this may look a little bit different, but I meet all the criteria, so it's still a normal sinus rhythm. This is also a normal sinus rhythm, but there's a little bit of artifact, and the P waves aren't as prominent. That's fine, because they are there, all right? It's very consistent. Here we have the, let's see, we have the QRS interval, and then there's some lag time before the S comes back up to the isoelectric line. So the line where there's no electric activity, just that parallel line across the sheet. This would be known as an ST depression. Okay, so S to T is below the isoelectric line. That's indicative of ischemia, right? So lack of blood flow somewhere in the heart. Well, not somewhere in the heart, but in the coronary arteries, right? If this was ST elevation, it would be indicative of a myocardial infarction. So again, here's a slide here. We have the normal on the left, and all of a sudden we see ischemia on the right, so ST depression. Again, if this were ST elevation, so instead of a smiley face but a frowny face, you see what I mean there? It'd be indicative of a MI. All right, that's it. If you have any questions, sorry, we need to talk about the lab report real quick. I know that's super important. Let me pull the, gosh, I hope this allows me to upload this to Sakai. I'm sure it will. I hope you guys can't see my bedroom right now. It's super messy. All right. So, for your lab report, you do not need a calculations section, so don't worry about that. You do need your data collection. This data collection, right? Fill it out. Don't make a new one. Make this one. You need all of these heart rates. All right. If yes, you need all of these beats per minute. The box estimation, I think we went over that. If not, jump online and find it. It's a very simple calculation using the numbers 300, 150, 175. It's just an estimation of heart rate. So find that. Mark out the cycling or walking on a treadmill for 1 minute because we didn't do that. And then your group members should send you a very crisp ECG that you can put right here. On that ECG, you need to label at least one P, Q, R, S, and T wave. You need to check out your PR interval and QRS interval at the top left of the page and write the norms of what it's supposed to be. All right. What else do you need to do? You need to also label all of the areas of the heart that each lead looks at, right? And check out your axis deviation. So you'll see, let me pull out one of mine so I know what I'm looking at. I don't have one. Oh, hold on. Give me a second. All right, I'm back. Not that you really knew I was gone, but you know. So we've got our report, and at the top left it'll say PRT axes, and it'll give you 3 numbers. Look at that middle number, and that is your axis deviation. You need to figure out what that means and tell me if that's a normal axis deviation, left axis, right axis, or extreme right axis. So look that up, and I want you to say, you know, yes, no, it is a normal, it isn't a normal. Put the chart that is commonly found online. So I'd like you to draw that. It's a good representation of the degrees of each axis. you'll go, type an axis deviation, like chart or graph, and it will come up with the 4 quadrants of what is normal, left, right, and extreme right. All right. And then I would like you to talk about if you did see a left axis deviation or right axis deviation, what are 2 reasons that you may have seen that? All right. So 2 issues in your body that causes a right axis and 2 that causes a left axis. All right. Write those both in your discussion, all as question 4. All right. And that's it for that. You don't need an exercise ECG. Answer all of these questions. Answer them well. They need to all be referenced as usual. And yeah, you see this? Be very specific for the bonus question. Let me make sure that I'm not missing anything. You do, again, you need an abstract as normal. And I don't think there's that much. Oh, you need a add a subject characteristics table. So at the beginning of your results, you're going to have a table 1, subject characteristics, just the basic stuff, age, gender, height, and weight, and then, again, attach your ECG. This should be fairly easy. You know, average grade so far is probably around the 90 or whatnot, as usual. So get this done. If you can get it to me by Friday at noon, that's fine. If not, please scan it to me, and we'll go from there. All right, scan it to me by we'll say let's do Wednesday at 5 p.m. Right? I think that's fair. So I'm gonna stop the presentation. Contact me if you need help, but if you think you can figure out, do that as well. All right. Bye bye. Love you all.